Hello everyone, my name is Vanessa and I will be presenting on this clinical scenario for the SOAP note. Patient HA, date of birth July 26, 1955. Patient is a 66-year-old Hispanic female who presents to the clinic by self for complaints of fatigue for 1 month. Patient does appear to be a reliable historian, so the chief complaint for the patient's visit is fatigue for 1 month. So for the HPI, patient presented to the family practice clinic for complaints of fatigue over the past month. She also reports associated muscle soreness, inattention, excessive sleepiness, and gradual unintentional weight gain. Patient reports a weight gain of around 5 pounds over the past month. Also, patient complains of feeling excessively tired when doing normal activities of daily living. Patient denies any fever, chills, headaches, chest pain, shortness of breath, nausea, vomiting, melena, or anything like that, as well as denies any changes in her dietary intake. Patient does report drinking coffee or caffeine in general without relief. Patient also reports taking her medications, such as her thyroid medications, every day in the morning before breakfast. Patient denies any other complaints or concerns. So patient does have a history of hypothyroidism and hyperlipidemia. She denies any previous hospitalizations or surgeries. She does say that she has her COVID vaccine and her booster. She received her flu vaccine as well, and also received her shingles and pneumonia vaccine, and as well as all her childhood immunizations. No known allergies. She does take levothyroxine 50 mics orally daily before breakfast. For her high cholesterol, she takes atorvastatin 20 milligrams orally daily at night, as well as calcium 600 milligrams orally daily before breakfast. So for family history, her father passed away at 81 years old, history of stroke, hypertension, hyperlipidemia, and diabetes. Mother is alive at 89 years old and has a history of hypothyroidism and hypertension. Brother is alive at 63, history of hypertension, and her sister is alive at 71 years old, history of hypertension and hyperlipidemia. So she does have history of hypothyroidism, as well as her family history of hypothyroidism as well. Patient does deny any alcohol, tobacco, or illicit drug use. She also denies any recent stress or recent life stressors as well, any big events that happened to her. She does live in a single bedroom apartment with her husband and also reports caffeine intake around 2 cups per day. She does report performing all her ADLs independently. So generally the patient reports fatigue, weight gain, and hypersomnia, denies any changes in appetite, fever, or chills, denies chest pain, palpitations, edema, denies cough, shortness of breath, wheezing, denies nausea, vomiting, constipation, diarrhea, or blood in the stool. She does report of muscle soreness, but however, denies any swelling, decreased range of motion, or muscle strength change. She denies headaches, syncope, paralysis or seizures, depression, anxiety, mood changes, hallucinations, or any abnormal bleeding. Her vital signs are stable. Temperature is at 97.7, heart rate 62, blood pressure is 116/79. She's citing room air 99%, and denies any complaints of pain. Overall, her BMI is 27.8, so it is within the normal range. Physically, she did appear to be a well-nourished, a little bit overweight female who does appear fatigued, but without any acute distress. She had a regular rhythm and rate, no rubs or murmurs. Lungs were clear. No wheezing or crackles or anything like that. No lymphadenopathy was noted. She did have appropriate range of motion. The The skin was cold to touch, but it was well perfused. Capillary refill was less than 2 seconds, and the skin was dry and intact as well. Patient was alert and oriented. So for differential diagnosis, the primary diagnosis was hypothyroidism. She does have history of hypothyroidism and does currently take a medication for it, as well as having a family history of hypothyroidism as well. So she did report starting calcium supplements recently at the time. So at the same time that she started taking the levothyroxine, and I did not know about this before, but calcium does kind of alter the effects of levothyroxine. So the patient is also having the signs and symptoms of hypothyroidism, so fatigue, weight gain, muscle aches, and hypersomnia. Another differential diagnosis was anemia, but it wasn't chosen as the patient denied any shortness of breath, dyspnea, palpitations, nosebleeds or blood in the stool, no active signs of any bleeding anywhere. Another differential diagnosis was congestive heart failure, but it was not chosen as the patient didn't present with any chest pain, shortness of breath, or edema or crackles in the lungs. So the final diagnosis came out to hypothyroidism. So the plan was to order laboratory tests such as TSH, thyroid panel, so T4, free T4, T3, a CBC as well to rule out any anemia, a CMP to check kidney function, liver function, as well as UA to see if there was any infection, such as UTI. So the plan for her also was to stop taking the calcium supplements until the CMP came back as well. Also to continue taking the levothyroxine in the morning at least 30 to 60 minutes before breakfast, and to wait at least 1 hour before taking any other medications or supplements with the medication. Also educate the patient that treatment for hypothyroidism is lifelong. The patient needs to continue this medication and the patient cannot stop it. Depending on the labs, there is a possibility of increasing levothyroxine to 75 mics, depending on the results. And patient needs to monitor the thyroid levels every 4 to 6 weeks until the levels stabilize, and also tell the patients about signs and symptoms of myxedema coma as well, and to reassess in 4 weeks for the thyroid function.